So this is a presentation on screening for obesity and cardiovascular health during the well child visits. The objectives of this presentation are to describe the evidence base for the current obesity prevention and treatment recommendations, to apply the elements of the Health Disparities Collaborative and the chronic care model to integrate evidence-based obesity strategies into practice, and discuss motivational interviewing techniques for childhood obesity. So BMI of 95th percentile or greater is defined as obese. And you can see that the prevalence of obesity in our country has gradually increased from the 60s up until late 2000. We had quite an increase going, with nearly 20% of the 6 to 11-year-olds kind of peaking there in 2007, 2008. And it began to level off just a bit. And in the last few years, the data are being collected a little bit differently, looking at the prevalence of obese and severely obese only. And the prevalence of overweight is a BMI greater than or equal to the 85th percentile, but less than the 95th. So when we lump these two groups together, both the obese and the overweight, you can see that the data suggest in 09-10 that these 6 to 11-year-olds, it was reaching about over 35% and close to 40% of the children falling into those two categories. Another alarming piece of data for you to be aware of is that there are ethnic disparities related to overweight and obese. And this graph depicts for you the Mexican American and non-Hispanic Black have a much higher prevalence of overweight and obese, with a BMI greater than the 85th percentile than the non-Hispanic white. And likewise, the same is true for obese youth with a BMI greater than or equal to the 95th percentile, with the Mexican American and non-Hispanic Black being far more likely to have a BMI greater than or equal to the 95th percentile. There are a lot of known health risks associated with obesity. These include pulmonary disorders like sleep disorders, asthma, and obesity-linked hypoventilation syndrome. Also, you can have neurological consequences with pseudotumor cerebri. There are a lot of orthopedic consequences for overweight, obese children with the extra weight on their bones, and slipped capital epiphysis, tibia vera, tibia torsion, genu valgum, flat feet, ankle sprains, and fractures are all more common in overweight or obese kids. There are also cardiovascular consequences that include hypertension, dyslipidemia, some fatty deposits, and especially associated with the central adipose tissue and left ventricular hypertrophy. There are some other consequences like systemic inflammation and the central obesity or waist circumference, which is also associated with endocrine complications. Gastrointestinal consequences may be gallbladder disease, non-alcoholic fatty liver disease, and gastroesophageal reflux. The endocrine consequences, as we mentioned, insulin resistance or type 2 diabetes, and the physical findings you may see associated with that are acanthosis nigricans, which is that leathery, thickened, dark color around the neck or in the axilla in darker skinned children. That's very much associated with the insulin resistance. In girls, you may see menstrual abnormalities and polycystic ovarian syndrome, and children may also experience hypercortisonism. There are some psychosocial health risks as well. And a study by Wright and colleagues showed that for middle school students, school performance was affected. Students with a BMI greater than the 85th percentile had lower grades and lower physical fitness scores, with GPA being almost a half a letter grade lower than normal weight students. And the students with the BMI greater than the 81st percentile had more detention, poor attendance, tardiness, and less participation in athletics. Another study by Schwimmer and colleagues found the quality of life in obese children reported by the children and their parents rated similar to children with cancer. Another sort of worrisome statistic is that if a child is obese in adolescence, 80% of them are likely to go into adulthood with obesity. So we know that the leading causes of death in the United States are linked to obesity. So children who are obese as adolescents and go into adulthood with that obesity are at much higher risk of heart disease, cancer, and stroke. So a variety of professional organizations have published guidelines and recommendations for us for the prevention and treatment of childhood overweight and obesity. The National Association of Pediatric Nurse Practitioners published early on in 2006 their HEAT guidelines, which were specifically directed at identifying and preventing overweight in kids. A year later, the expert panel recommendations were published in Pediatrics, and this was a group of interdisciplinary collaborators, Maternal Child Health Bureau, the AMA, and the Center for Disease Control supported that work. AAP Bright Futures has also published recommendations. The Pediatric Metabolic Syndrome Working Group has recommendations, and NHLBI has recommendations. And their recommendations for the clinical practice guidelines for screening and management of high blood pressure have just been updated and are included in this presentation. The HEAT guidelines were developed by a group of pediatric nurse practitioners from all across the nation, getting together and reviewing all the existing evidence and coming up with guidelines. They looked at Institute of Medicine, NHLBI, the American Heart Association, the U.S. Department of Agriculture, American Dietetic Association, and the AAP, as well as Cochrane Collaborative Reviews. And I had the pleasure of working with this group, and the guidelines are specifically focused for pediatric nurse practitioners to help guide your practice in this area. These HEAT guidelines have several areas of major focus, and that included the early identification of overweight, the communication and developmental considerations, nutrition essentials, but also feeding and eating behaviors, physical activity as well as sedentary behavior, and the role of the nurse practitioner as an advocate in their communities. So the difference in these particular guidelines were a strong focus on the family, age-specific feeding and physical activity recommendations, the emphasis on a professional family partnership, the advocacy recommendations, and the cultural implications. These guidelines include specific recommendations for all age groups. The universal recommendations are a generational family history, asking about any overweight, obesity, hypertension, diabetes, cardiac disease, and stroke, passive smoke, and parental BMI. There's a very strong correlation between parental overweight and obesity in children. And as a matter of fact, if you have two overweight parents, you're 13 times more likely to be overweight or obese than a child with normal weight parents. So the clinicians charged with calculating the BMI, graphing the height and weight and BMI percentiles for all kids age 2 and older, a weight for length ratio on the World Health Organization growth charts for kids under the age of 2, and counseling or discussing with the parents the growth measures, the sedentary behavior, and the eating behaviors. The assessment needs to include activity as well as inactivity and diet. There are a variety of tools to help you with calculating the BMI, although nowadays most of the electronic health records do this automatically for you. If you're in a setting that happens to be using growth charts or does not have an electronic health record, you can use this CDC calculator. These are the CDC growth charts, which you can download online, and again, use the World Health Organization charts for the children under 2, and they're also posted on the CDC website. Laboratory screening recommendations is one area where the guidelines from all the different groups don't exactly match. But the recommendations in general these days include if the kid has a BMI greater than or equal to the 85th percentile, but no additional risk factors, you get just a lipid panel only, and you can get it without the child fasting because they found none of the children were fasting and we were missing an opportunity. If this comes back abnormal, you follow up with a fasting lipid panel. For children with a BMI percentile greater than or equal to the 85th percentile, plus 2 risk factors, those could include things like family history, elevated blood pressure, elevated lipids, or tobacco use, then you want to get the lipid panel, you want to get some liver enzymes, and you want to get a glucose or a hemoglobin A1C. And for children with a BMI greater than or equal to the 95th percentile, you're going to get the lipid panel, the liver enzymes, and a glucose or the hemoglobin A1C. And again, if anything's abnormal, you'll follow up then with the fasting labs. This slide includes the cut points for children and adolescents for the lipid panel. And you can see the borderline range, the acceptable, the borderline, and the high range. And again, if a child exceeds the cut points for any one of these, then you follow up with a fasting lipid panel. Now let's turn our attention to hypertension and whom and how to screen. So children aged 3 and older should have an annual blood pressure checked with their well-child visit. If the child's obese or on medications for hypertension or any other indication that suggests the kid might be at risk of hypertension, renal disease, or something like that, you're going to get their blood pressure at every visit. Children under the age of 3, if it's indicated, and again, any worry about renal disease or any medical complications that may be associated with hypertension. If the blood pressure is greater than the 90th percentile, you're going to recheck it twice at the same visit. Children can sometimes be anxious, and it's that anxiety that makes it high. A diagnosis of elevated blood pressure or hypertension requires an elevation on 3 separate occasions. So you are going to see the child back on another visit to determine if they actually have elevated blood pressure. Here are recommendations on the dimensions for the blood pressure cuff bladders for the various age child, but just be sure that you're using the right size cuff because it can cause either an overestimated or an underestimated blood pressure. The definitions of the various blood pressure categories have just been revised in this 2017 practice guideline for screening and management of high blood pressure in children and adolescents. And the emphasis remains on using the right size cuff and using the NHLBI, using the tables that are published in the article, and refer or co-manage any children with hypertension along with specialists. So the developmental factors in communication, some examples of those include assessing school behaviors, eating activity, junk food. We want a Tanner stage documented. It's a sexual maturity rating. If this child is still going to grow taller, they may actually be able to grow into some of that weight, where if the Tanner stage is already 4 or 5, they're not going to be getting much taller, and you really need to focus on helping them get the weight to a healthier range. We're going to get blood pressure percentile for age, sex, and height, and again, it's using those charts. You're going to discuss the physical, psychosocial, and emotional changes, collaborate with the family and the child to set goals and ask which of the recommendations might work for them, and encourage these parents to model a healthy lifestyle as well. The nutrition essentials and optimal feeding and eating behaviors. We encourage family meals, breakfast every morning, limiting sweetened beverages, providing a variety of foods from all food groups, really talking to families about portion control, and include friends and family members when you can. The current recommendations around physical activity are actually extrapolated from the adult guidelines and include at least 60 minutes of physical activity daily. Most should be moderate or vigorous aerobic physical activity with some muscle strengthening 3 days per week and bone strengthening 3 days per week. And it should be appropriate for the age of the child, and most important, I think, is enjoyable, so they want to go out and play and have fun, and don't see it as punishment. Limit screen time to 2 hours per day, no TVs in the bedroom, and encourage a variety of active play options, preferably outdoors if it's safe. Sleep has been associated with overweight and obesity as well, and a lack of sleep correlates with children putting on excess weight. So you really want to assess sleep behaviors and recommend that there's a regular bedtime, a bedtime routine, limit any distractions in the bedroom, so no TV, no cell phone, no computer, and the adequate duration for their age, which will be 9 to 11 hours depending on the age of the child. The advocacy work depends on the community that the clinician is in, but some examples could be supporting breastfeeding, having home, work, community, and child care policies that support the breastfeeding mother, advocate for safe, affordable recreation, advocate for after-school programs to promote physical activity and or improve nutrition, advocate for nutrition and physical activity policies in the school or child care setting, and advocate for environmental changes in the community. So let's talk some specifically now about the expert panel recommendations around treatment. And these come from those AAP, AMA, Maternal Child Health Bureau recommendations. So they included prevention, assessment, and treatment, and there's separate papers actually for all 3 aspects. They suggested that you use the chronic care model to address overweight and obesity in children and look at systemic things that could be done in the healthcare system to remind the provider and support them in identifying and assessing these children at each visit. The treatment guidelines are for a BMI between the 85th and the 95th percentile. You do the assessment and the prevention or stage 1 treatment. And for a BMI at the 95th percentile or greater, you move on to stage 1 and progress as needed. So stage 1 is called Prevention Plus, and the columns on the slide are the what on the left-hand side and how and who on the right-hand side. So we're going to encourage families to have 5 servings of fruits and vegetables per day, and that needs to replace the energy-dense foods. So they can't just eat 5 fruits and vegetables in addition to all the chips and candy and pop and all that kind of stuff that they normally eat. It has to replace those energy-dense foods. We're going to limit television to 2 hours per day, encourage them to take the television out of the bedroom or never put it in there, decrease sugar-sweetened beverages, talk about portion control, what's appropriate for that size age child, encourage daily breakfast. Skipping breakfast is correlated with increased weight. Decreased eating out or helping families plan for healthy choices when eating out. Family meals have been correlated with normal weights, and at least 60 minutes of physical activity per day. The counseling around those recommendations can be done in the primary care provider's office, can be done by the PCP or staff, and many times a combination of roles in the provider's office can be most time efficient. The visits are based upon the readiness to change and the severity of the condition, and you advance to a higher level or the next stage based on the medical condition, the length of time they've been there, and the family's readiness to change. So stage 2 is considered structured weight management, and it includes everything that we talked about in stage 1, but it also includes a targeted effort to decrease calories and provide a balanced macronutrient diet. It includes the decreased screen time, a focused behavior change counseling, and some self and or parent monitoring. And who can do it? The PCP's office plus a dietitian. And it sometimes works to connect with community programs so that they get a little more specific content on the nutrition. The visits are usually monthly and tailored and based upon the readiness to change and the severity of the condition. There may or may not be need for support from mental health provider along with this. If you're trying to really counsel on behavior change, that can be very beneficial. And again, you advance based upon their progress, the age of the child, the medical condition, the risks, how long they've been there, are they making any progress or things getting worse, and the family's readiness to progress. Stage 3 is a comprehensive multidisciplinary treatment. It includes everything that we've already talked about, but more frequent visits, usually weekly. It's structured monitoring with assessment measures so that clinicians in the office are collecting the measures weekly. It's a multidisciplinary approach with a dietitian, some behavioral health or psych provider, maybe a physical therapist or someone for physical activity. And it can be the clinician, either a physician, nurse practitioner, or a PA. Usually behavior modification training for parents is included, and that's usually done by the behavioral health person. This one requires strong parental involvement and commitment, and group sessions have been proven effective in some practice settings. So the PCP coordinates the care for the structured weight management program, but they may actually refer, when available, to somewhere in the community or co-manage with experts if there's not a weight management program available to their patients. We've already mentioned it's an interdisciplinary team, weekly visits with some goal setting and monitoring, and again, they'll advance to stage 4 if they continue to have no progress and the health risks are increasing and they're motivated to move on to stage 4. So stage 4 is a tertiary care treatment. You should consider referral for medical, surgical, meal replacement therapy to supplement the behavioral therapy if the child's health is deteriorating and they're not making any progress with what you've done in the first 3 stages. And for pediatric weight management centers in the Denver area, the Children's Hospital Colorado has a good program. It includes multidisciplinary team with experience with children and adolescents, and they have visits according to their clinical protocol. The advocacy guidelines, there's a nice booklet put together by NICHQ. The Be Our Voice talks about all the ways that clinicians can advocate for healthier weights in children. There's a variety of resources available online, and certainly the NAP Heat work, the CDC, and the Get More Energy, the North Carolina group. They all have a variety of resources that you can access online. There are some clinician tools, including a prescription pad, some of the research that's been done on actually writing a prescription for physical activity or eating healthier or sleep plans have been proven to be helpful to families in getting them to follow through. Somehow it makes it more official what you're asking them to do. NICHQ also has this online community focused on childhood obesity that you can use. And the last part of the recommendations, both the HEAT guidelines and the AMA, AAP recommend using motivational interviewing to counsel the families. And the purpose of MI is to create this partnership with the family and set some joint goals and help them identify what they can change. So the ideas are, it's a real shift in us as the clinical experts telling families what to do versus empowering the families to identify what they can change and making it real client-centered and collaborative. And it focuses on their individual beliefs, and you as the clinician believe in the client's abilities to make the change. It includes a lot of positive reinforcement and provides tools for changing behavior. So the steps are first to establish rapport, set the agenda, assess the importance of making a change, their confidence in their ability to do that, and their readiness to make change. And then you'll explore the importance and build their confidence. So this video is just an example of how the discussion might go with a family at a well-child visit. Hi, Mrs. Nichols. Hi, Jessie.
Hi.
Now that we've gotten your height and weight and your history, is it okay for us to talk a little bit about how you're growing and ideas of ways to keep you healthy?
Yes, yeah, absolutely.
Okay, so let's start with your growth chart here. And it looks like your weight is about the 50th percentile and your height is about the 25th percentile. And your body mass index, which is an estimate of the body fat is a little bit above the 50th percentile, but really
Okay.
all of those are kind of in the normal range.
Well, that's good.
That's great. That's great. So based on your history and what you told me about your family history and your eating and activity, is it okay for us to talk about some things, ways to keep you in that healthy range and keep you growing healthy?
Yes.
Yeah.
Given our family history, it would be important.
Yeah.
I want to
okay.
keep her in that range.
Okay, sounds good. Well, you know, you said there was a family history of high cholesterol and some heart disease, and there's nothing we can do about that. So
Yeah.
we just have to change the things we can to keep her in this healthy growing. So some things you told me is that you are physically active every day, about 30 minutes, and that's great. But the current recommendations are an hour of activity every day.
Right.
And you're eating breakfast about twice a week, and we know for children and pre-teens like you that those who eat breakfast every day are less likely to have a problem with being overweight. So that's one area that you could consider.
Okay.
And then I noticed you're not much of a milk drinker. So
No.
one thing we know about, again, the pre-adolescence, your bones are going to be growing, and you need that calcium for the bones to grow. So
I didn't think about that.
that's another area that you could think about. And then it looks like fruits and vegetables you're taking about 2 times a week. So the current recommendations are 5 servings of fruits and vegetables every day. So with your normal growth here and your family history and those considerations, is there anything that you think that would be important to change about your eating or activity?
Well, I mean, I think the breakfast one would be the easiest to start with. And I mean, I would like to be able to do it about 5 times a week to start out with. But being a little bit more realistic, I do like to sleep in, so that would kind of be a problem.
Okay. So you think it's
Well-
important?
Yes, I think it's important. Very important.
So,
Yeah.
so it sounds like maybe breakfast would be the thing that would be the easiest to think about changing. If you decided you would do that, how confident are you that you would be able to eat breakfast every morning before school? Because what you told me is you like to sleep in.
Yeah.
So if you went on a scale from 1 to 10, with 1 being not very sure you could do it every day, to 10, yep, absolutely, you'd eat breakfast every morning, what number would you be?
Well, if we were talking on a 5 days a week scale, about a 5, maybe even a 4, because
Okay.
I'm just not very confident I could do it every single morning. But if we were to say maybe 3 days a week, I would be about 8, 9.
Okay, so that would be more manageable, huh?
Yeah.
Okay. So what would you,
Actually, I could help, by providing the food, and if you forget, I could remind you, that
Okay.
kind of stuff, yeah.
okay. So what kind of plan would work for you guys? Because it sounds like you're currently not doing the breakfast every morning, so, and you like to sleep in, so
Yeah.
how would that look if you decided you would do that?
Well, I'm really not sure how that would work because my mom really doesn't like any the food substances in her car.
Okay.
Yeah, I think I could be a little more flexible with that, yeah,
Okay.
yeah.
Okay. So.
Given its importance, I could be flexible.
Okay, so what would the plan be if we decided, how ready are you to come up with a plan? Are you ready to do this?
If we were on a scale, I guess about a 10, yeah.
Yeah? Okay. So what would the first step be?
Probably getting the food in for the first time. For the first couple of days, just making sure that I actually get the food into my body and that I'm ready for that day. But after a while, it'll just get a natural routine.
Becomes more of a habit the more
Yeah.
you do it.
Yeah, and like I said, I could, get the food and then remind her when she doesn't remember.
Okay. Sounds like we have a plan.
Yeah.
So we're gonna try what for breakfast?
Cereal.
Sure. What about those days that we're running late on, say, time? Like something quick and simple. Because
If you could grab and eat in the car,
that you could grab and eat.
so you're not getting up early.
Well, we could, figure out something. So it could be like, I don't know, maybe a piece of fruit to build up my fruit intake, or maybe some yogurt to get myself some more calcium.
Right.
Yeah, that would hit three things that you told me that were kind of a problem. You'd be eating breakfast, you'd be getting the calcium in the yogurt, and you'd be increasing fruits and vegetables. So that would be a really kind of like a triple strike.
That's good.
Sounds good.
We'll work on that.
Okay.
Okay, that sounds good. Well, if you wanna try that for a couple months and then check back with me, we'll just see how it's going.
Sure.
Okay.
Sure.
Okay.
And then I'll follow up with making an appointment.
That
for
sounds
follow-up.
good.
Okay.
Okay.
We'll see you in a couple months.
All right.
Got
Thank
it.
you.
Mhm. And then finally, I want to remind you, don't forget to provide a prescription for health based on the patient's goals and what they state they can do. So in the case of this young lady, you would write the prescription out that she was going to increase the number of mornings that she was taking breakfast, that she was going to increase fruits and increase calcium, and then follow up, set the appointment for follow up. Here's some resources for you related to this topic. And good luck as you see these children in your practice. Every one of the well child visits should be assessed for weight, and the counseling should take place just like it did for this young lady, even though she was in the normal range for her weight.